Thanks for the nice introduction. And this is the last session, I hope, and post-lunch session. So I hope people are not sleeping and taking some interest in this. So I would be talking about pediatric epilepsy and how to approach a case of pediatric epilepsy on imaging. So these are some of the entities which can lead to seizures in children, which includes most importantly cortical malformations, neurocutaneous syndromes, then some lesions like cavernous hemangioma, then certain tumors like ganglioglioma, DNET, pleomorphic xanthoastrocytoma, and apart from that, MTS is there. So coming to MRI, so CT is important, especially in our country as well as in the South Asian region, where infections constitute an important cause of seizures, and because they tend to get calcified, the lesions tend some of these calcification produce these infections produce calcified lesions. So CT plays an important role, and also CT has got its role because when the patient comes to the emergency, it is very easily available and it is easy to do. And already Dr. Ajay has shown a spectrum of imaging manifestations in patients with cysticercosis, and what are the features based on which you can actually diagnose them. And coming to epilepsy imaging using MR, so MRI, those patients who continue to experience seizures, they need to undergo an MRI for better characterization of the lesion, as well as whether lesion is present or not, because CT is not a very sensitive investigation for rest of the pathology. So we do, which include, so when we come to evaluation of these subjects, these are some of the methods. What are the conventional MR technique? Then there are some standardized protocols which have been published and advocated by the they are part of guidelines. And some quantitative methods are there, and then functional imaging before the surgery. What are the standard sequences which are useful? Then one most important of them is you do an isotropic 3D T1 weighted image, do a T2 high resolution T2 coronal images with a high spatial resolution, and they should preferably be 3 millimeter or less in slice thickness. Same comes to FLAIR images, and you can use a T1 weighted inversion recovery. And pediatric patients less than 2 years, proton density is useful because FLAIR doesn't give you enough information at that time. And high resolution volume acquisitions, which includes FLAIR as well as T2 weighted images, which can be useful. I'll show you the value of those acquisitions in the subsequent slides. Coming to planning, we can do acquisitions along the ACPC line and also along the hippocampus. And when we are, and the coronal section have to be taken perpendicular to the hippocampus. And the planning is very, very important, but because the presence of asymmetry can give rise to false lesions. And so one of the easy ways of doing it is that identify the internal caustic meatus, and you can make a perfect plane, perfect coronal planes using this landmark. And also we have to balance between the length of the study as well as the possibility of movement, because the longer it takes time, you get better images, but then the likelihood of movement artifacts also increases. So we have to make a compromise between the two, whether you want an very good images and how cooperative the patient is. But I believe that in an epilepsy scan, we should focus on one good quality scan, and sometimes we even those patients who are not cooperative, we advise a MRI under anesthesia. And these are some of the images which you can some of the acquisitions and how they can be reconstructed, and you can look at those. But the most important thing is that we must analyze, when we are doing these scans, we try to get a good quality scan, use the best quality sequences. There are no shortcuts, because a lot of times because of a bad scan, we miss we are not able to diagnose the underlying condition. What if a standard epilepsy MRI is negative? What can be done? So do we need to do an additional sequence? What is the use of these additional sequences? which sequences are more useful and should we use them routinely. And then there is a absolute importance of multiplanar reconstruction. So this was a study which I always show, which I, as a resident, I wrote when I was in Chitra. And that time also in 2007-8, we were doing all epilepsy scans with a 3D sequence, the 3D flare. And it used to take around 7 to 8 minutes, but it was part of our protocol. And actually, we tried showing in this particular study that it's important to do a 3D flare because we can identify the lesions much better, and you can actually do a multiplanar reconstructions using this. So these are this is a 1.5T scanner, very old images, but you can still see how nicely this particular sequence actually is depicting the lesions. And also this is a focal cortical dysplasia. And then there are studies which have used double inversion recovery imaging, which again is very good for identifying small lesions. Although my own experience has not been very great with the DIR sequence. You can see in this particular this study where there's a small lesion which is not seen on double inversion recovery on the flare images, but you can very nicely see the one focal lesion, one focal abnormality in the left insular region. And recently there have been a series of studies which have used this fluid as well as white matter suppressed imaging. They call it FLAWS. The original paper came in Neuromage in 2018, and they could actually demonstrate that there were some subtle lesions which could be identified very well using this technique compared to 3D flare. I'll show you some more cases with this particular technique. And also one more value of using an inversion recovery method is that it can depict the perilesional gliosis very well. And for example, in this particular case, you can see that there is a very small lesion here, and you can barely see the signal abnormality on a flare image, but you can actually see multiple areas of signal changes on the double inversion recovery. So perilesional gliosis or a signal abnormality or a edema can be very well identified using this particular technique. And apart from that, we always do SWI for in all the cases of susceptibility weighted imaging, which most of the centers use as a standard protocol. And you can see in this particular case, you can see this is if you look at the regular images T1, T2, and flare, you can hardly see any abnormality. There's a subtle hyperintensity seen here, which is very difficult to detect in the regular if you are just not careful enough on flare images. Double inversion recovery actually shows these signal changes much better, and you can see that now you are able to see the signal abnormality here. But look at the susceptibility weighted imaging, which shows there's a small calcification present here. Phase is confirming that, and you can see on a 3D T2 sequence, you can see that there's a focal gliosis, which is very difficult to appreciate on the other images. So I'm saying that sometimes in an MR negative case or a case where a lesion is there and we want to characterize it, certain additional sequences can help us in letting us know the exact nature and the location of the lesion. And there's another aspect of using susceptibility weighted imaging. This is a very interesting case, which we recently, just a couple of weeks back, we saw this. This patient got admitted. He was having a medulloblastoma. And you can see these are two scans done on 2 different days. So on 7th October, he had a seizure. And after that, this study was done. And you can barely see anything there's hardly any difference in the 2 flare. One is on 28th September when he was not having before the seizure, and this is after the seizure. But now you see there's no diffusion abnormality, there's hardly any T2 weighted abnormality, and this was the SWI on 28th September, and this is the SWI on that particular day when he had a seizure. And you can see the blanched appearance on the left complete cerebral hemisphere, and on ASL you can see there's increased perfusion in the left hemisphere. So periictal, postictal abnormalities can be very well detected using these functional sequences, namely the diffusion weighted imaging, which can show diffusion restriction after the seizures and can actually help you to localize the seizures in some of the cases, focus of the seizures. And SWI can also give you an ancillary information. Similar is the case with the ASL perfusion. So there are so many techniques of doing perfusion, but we usually use ASL because usually we don't give contrast in the patients who are coming with the seizure for evaluation of epilepsy. And in those cases, we do just ASL because it doesn't require any contrast. These are the various techniques we use in our scanner, mainly PCASL and PSL based methods. So what is the value of this addition of a perfusion scan? It takes around 4 minutes time. Look at this particular study actually. If you see here carefully, there is a focal abnormality in the left occipital, but it is very difficult to make out on the regular scans. But look at this on the perfusion scan, you can see there's an hyperperfusion not only in this region, but also going into the occipital and as well as into the parietal lobe. So this patient was having very high interictal spiking, and that was the reason why. So sometimes you can actually localize based on these kind of additional methods. So we have to be judicious when we are using these methods because it takes time. Your exam times get prolonged. This is a case of Rasmussen's encephalitis where you can see that multiple areas of signal abnormalities are there in the left side hemisphere, and on the corresponding ASL images, you can see there's an increase of fusion actually. And actually FDG PET is also showing increased metabolism in those locations. So, so these are the imaging correlates of ongoing seizure activity or ongoing interictal spiking in these particular subjects. Some newer methods like MR fingerprinting is actually slowly coming into the clinical domain. And this is in this slides I've taken from GMRI paper where they have shown that how the lesions which are, for example, this particular heterotopia. So there are multiple heterotopias are there, but the relaxation times of the heterotopia, which is a potential source of seizure activity, is showing a different T1 relaxation measurements as compared to the rest of heterotopia. So when multiple lesions are there, you can actually use this kind of methods. This is another case where you can see that the right side temporal lobe area where hardly any abnormality we can appreciate on T1 weighted images as well as on the flare, but you can see on a T1 map underlying white matter abnormality can be actually be seen. So so these are the some of the uses of these newer techniques. And similar, you can go through this paper which got published in Radiology a few years back, where value of using MR fingerprinting has been documented. And there is an some case reports are there where people have used another aspect of imaging, which is bold MRI, and they have tried to identify an epileptogenic lesion. This is a report from published in the Neurology, where actually they used the local connectivity measurements, and they could demonstrate that there's in an MR negative epilepsy case, there was a focal area which was showing higher local connectivity, and PET was showing hypometabolism, and interictal SPECT it was showing increased CBF value in the same region. So this patient underwent the surgery and a lesion could be identified. So there are sometimes you require out of box solutions to certain problems. So these are the common causes of epilepsy: MTS, developmental problems, epileptogenic tumors, gliotic scars, neurocutaneous syndromes, and entities like Rasmussen's. So we must have a checklist for structured approach, which includes look at the hippocampus, fornicis, mammillary body, ventricular outline, so that you can identify heterotopias, sulcal morphology or CSF clefts, gray matter thickening or thinning in any focal area. So you need to have a high quality T1 and 3D flare sequences, blurring of gray white matter junction, T2 prolongation, presence of a paramagnetic artifacts, atrophy. And another important aspect is that you must remember that sometimes they look for subtle encephalocele, especially in the skull base. Sometimes they will be missed because we'll be focusing mainly on the brain, but sometimes small bony defects might be there through which the parenchyma is herniating and gliotic and maybe causing the seizures. So MTS findings: hippocampal atrophy, hippocampal increased signal, loss of internal architecture. These are some of the findings which we find in cases of MTS. And additional findings can include atrophy of the fornix, mammillary bodies, increased signal and atrophy in the cingulate cortex, increased signal and reduction of volume of amygdala. Collateral white matter has to be looked at. Then you can have a thalamic and caudate atrophy. You can have a complete hemispheric atrophy, or at left the same side temporal lobe atrophy. And contralateral cerebellar hemiatrophy can also be seen. Also, another aspect is look at the anterior temporal pole always, because there can be loss of gray white matter interface in the anterior temporal pole. So it's an ancillary finding. And also reduce white matter volume in the parahippocampal gyrus. For example, I will show an example. This is a 17-year-old male with the right side MTS. You can see the hyperintensity of the and the volume loss of the right side hippocampus as compared to the left side. Look at the T2 weighted images, which very nicely shows atrophy as well as the enlargement of the right side temporal horn. And overall, if you see, not much asymmetry is there. Caudate, putamen, and thalamic volumes look fine, but we must always remember these ancillary findings might be seen in some of the patients. And also, when we have identified the MTS, we should always look for other abnormalities. For example, in this particular case, there's an MTS is present, but that there's a left parietal focal cortical dysplasia is also there. So, and sometimes there can be a calcified granuloma present. So these are the other findings which we must identify because it may be a secondary MTS. So coming to focal cortical dysplasia, they can be of three types: type 1, 2, and 3. In type 1, no dysmorphic neurons or balloon cells are present. Type 2 has got a dysmorphic neurons with or without balloon cells. And type 3, the focal cortical dysplasia associated with another lesion. So what are the most important findings on imaging? On the MRI is a cortical subcortical signal alteration can be there. Look at the depth of the sulcus. Look for the blurred gray white matter interface. Look for the cortical thickening or thinning, transmental sign. I'll show you some of those examples. And type 1 is the one which is very difficult to identify. Usually MR studies are negative in these cases, but same they are further of three types: 1A, 1B, and 1C, depending upon the histological characteristics. And type 2 further of A and B. Type 2B is characterized by the presence of transmental sign. Otherwise, rest of the features we need to identify what I have already enumerated. So type 1, I don't have any good experience with the type 1. But this same study, which actually, as I mentioned previously, showed some type 1 cases which were actually missed on the regular imaging, but could be identified using this floss technique. But if you see carefully, even the FLAIR images here, you can very difficult to identify any abnormalities in cases of type 1 FCDs. This is another example from the same study where they have used the MEG to localize, and you can see this tail or transmental sign even in type 2B. But here in the type 1B case, a subtle at the depth of the cortex, there's a subtle signal abnormality which was not seen on the FLAIR images and could be identified only using this water and fat suppress, water and white matter suppress sequence. So type 1 is very difficult to identify. Usually MR is normal. You have to go for icter interictal SPECT subtraction methods or use a PET, which might show hypometabolism in the interictal period. MR, with the improvement in MR techniques, maybe use of an higher field strengths, we might be able to localize these lesions or use different techniques. As I mentioned, one of the methods which was taken from literature, which was able to identify type 1 FCDs. So this is as I mentioned, bottom of sulcus abnormality here. You can see this subtle signal change here, and which is very difficult to make out on the FLAIR, but there's a signal alteration here. In the zoomed view, you can see there's a tail here, and actually PET actually corroborates with our finding. There's a hypometabolism on that side. Sometimes they are not that difficult to identify. Here you can see grossly cortical thickening is there, underlying white matter signal change is there, and it is going to, I can see the signal changes passing towards the ventricular surface. On diffusion also, you can see these abnormalities in this diffusion signal. And T1 actually very nicely demarcates the lesion. and PET actually shows an hypometabolism in this lesion. In an periictal phase or sometimes rarely in the interictal phase, PET can also show increased metabolism. So what is transmental sign? It's a funnel shaped flare hyperintensity which tapers towards the lateral ventricle, as I showed you. And in case of FCDs, calcification and contrast enhancement are usually not seen. So if these things are seen, you have to look for an alternative. So this indicates arrested neuronal migration. And this is another case where you can see, so findings can be very subtle. Here, look at the abnormality. Subtle signal changes are there. Look at the gray white matter junction here, and on the right side, there's a blurring here. T2 also corroborates with it, and actually T1 weighted images very nicely demarcates the loss of gray white matter interface as well as the underlying white matter signal abnormalities. In this particular case, you can see not only that there's some sort of fullness in the right side occipital, and there can mass effect kind of thing is seen. And if you see carefully, and on the that this whole thing looks slightly swollen. Look at the cortex. Cortex is not looking normal intensity here. Cortex looks slightly brighter on T1 weighted images, and there's some islands of sparing in between. You can very clearly see, and it's the 3D T2 weighted images which also corroborates with our findings. And flare also shows. In this particular case, if you see, flare shows some underlying white matter signal changes, but cortical abnormalities are much better seen on 3D T1 MP. We should always actually optimize these 3D T1 weighted images for the epilepsy scans. We need to have as good gray white matter contrast or a distinction. So you can see in the zoomed view how nicely demonstrates the cortical abnormalities with some areas of sparing and some areas of signal abnormality. And here there's total loss of gray white matter interface. And same findings can be seen even on T2 weighted images. Coming to heterotopias, these are arrested migration problem, and they can be subependymal or subcortical. For example, this particular case, so always look at the contour of the ventricles to identify these abnormalities. Sometimes they will show all the features of similar to the cortex. Sometimes after seizure, there can be diffusion restriction in the heterotopia. For example, here you can see there's a darkness here, slight of hyperintensity can be seen here. Subcortical band heterotopia is an extensive form where you see another cortex-like band below the normal cortex in the white matter zone. For example, this particular case shows same findings, and actual diffusion imaging can show. So these are, we just know these entities, and then we can actually identify them very pretty easily. And these are the arrested neurons. You can see the radial information in this zone, intermediate zone actually. So this shows that there's a radial organization, persistent radial organization in this zone. Sometimes they will have a very bizarre, large cortical tumor-like lesions, which are again, you can see that in this particular case, even PET has been done. So this is pretty easy to diagnose, but PET actually shows metabolic activity within this area. So there's some viable tissue lying there. Coming to polymicrogyria, where you have to look at the gray white, look at this in the polymicrogyria, what we have to look at the cortex and the white matter junction. Here, look at the right side, it's very distinct, very nicely made out. It's very smooth, whereas in case of polymicrogyria, and there can be underlying white matter signal changes along with the distorted gray white matter context, which will be very, very irregular. Here again, you can see there's a fuzziness of or irregularity of the gray white matter contrast. This is the unilateral perisylvan polymicrogyria. You can have a bilateral perisylvan polymicrogyria. It can be associated with some of the metabolic disorders as well as with the other white matter diseases. So again, you can see here in the zoomed view, irregularity of the gray white matter junction, which helps us to diagnose this condition. We have to be very careful. It also lines the seismocephaly cleft. Again, you can see the seismocephaly cleft and the lining gray white matter, cortex, which is bumpy or which is very irregular. Again, another example of polymicrogyria. In lissencephaly, there's a smooth brain characterized by relative smoothness of the brain surface. There may be no gyri, there may be broad and less number of gyri, or there can be total smooth brain surface. And you can see multiple layers. It can be localized also. For example, in this case, bilateral parieto-occipital localized lissencephaly is there. There are so many genes associated with this entity, and they can have a some of them have a preference for occipital or the frontal lobe. Again, another case of where the number of sulci and gyri are looking much lesser, and the gray white matter distinction here, the cortex looks pretty thickened, and the distinction is very, very poor. On the T1 weighted images, you can see this very nicely. As I showed you previously, that it can have a very bizarre imaging appearances. For example, in this particular case. Now, another aspect which is very important to understand, that less than 2 years when myelination process is not complete, diagnosis of the malformation of cortical development is slightly tricky. I will show you, because the T1 and the T2 times of the are changing with the age. And at that time, for example, in this particular case, at 6 weeks, look at the abnormality here. At 12 months, look at the abnormality here, and 27 months, look at the abnormality here. So how the morphology has changed over a period of time. Here you can see that actually there's a cortical malformation which has totally changed in the morphology over a period of time. Actually, it can become less conspicuous. And one of the features which you can look at is look at the surrounding white matter, which can, for example, here, if you look at the 2012 months, look at the white matter here, which is showing accelerated myelination. Compared to rest of the places, this area, compare with the opposite side, you can see there's a more hypointensity here at the 12 months. So there's an accelerated myelination because of the seizure process around it. And so at this moment, it is easy to identify, but later on, because it becomes very, very indistinct. But it can go other ways around also, like 8 months, hardly able to make out any pathology here, but at the 17 months, you can see there's an extensive malformation present here. So sometimes when we are not able to identify a focal abnormality, it's very wise to repeat the scan once the myelination process is over, and compare those studies and see how the lesion is, if any lesion can be identified, and how the same area has evolved over a period of time. Epilepsy associated with the tumors include DNAT, ganglioglioma, pleomorphic xanthosarcoma, and hypothalamic hamartoma. Ganglioglioma typically present as a cyst with enhancing neural nodule, but some unusual appearances are also known. They can have a calcification, which is common in ganglioglioma, but it is a distinguishing feature from DNAT and the pleomorphic xanthosarcoma, and can be seen in nearly half of the cases. So this is a typical case of ganglioglioma. Calcification is there, cystic area is there, underlying white matter signal change is there, susceptibility shows the calcification, and they can sometimes show enhancement and can be actually pretty large and atypical in appearance. For example, this here, it is showing enhancement. There is no diffusion restriction. Always look for the temporal lobe MTS even when you have identified a pathology. This is an atypical appearance, large lesion with lot of hemorrhage present, and bizarre looking appearance. So, but it is also a case of ganglioglioma. Coming to DNAT, the classically described finding is a bubbly cystic appearance. You can see here, and they do not show any enhancement. There can be overlying cortex or bony changes which may be present, suggestive of their long-term presence, and there can be a bright rim sign on FLAIR images. Here again, you can see overlying bone is getting modeled by an hyperintense lesion, very nicely seen on T, and this margin of hyperintensity on the FLAIR images. No diffusion restriction, no calcification, or no hemorrhage present. Another case, you can see that small focal lesion, very nicely seen on all, can be identified very easily, and there's no enhancement suggestive of a DNAT. This is a bright rim sign. You can see marginal hyperintensity on the FLAIR images. Hypothalamic tubercinarium hamartoma, when they are small, they can be missed. For example, this particular lesion here, always look for this area, but sometimes they can be very, very large. Unfortunately, I am not having a case, but I have a case which has got around 6 centimeter large hypothalamic hamartoma. So sometimes they can be very, very large. So in those, we must be aware that they can be pretty large and can simulate a large to other neoplastic entities. But this kind of small lesions can be missed on image. We should be careful. We should be, whenever we are looking at a seizure patient scans, this entity must be clearly try to identify this abnormality. Look at this area. Pleomorphic xanthosarcoma, they are cyst with a mural nodule. That's a classical finding, which nodule abuts the pia, And there can be peritumoral edema, and there can be thickening and enhancement of adjacent leptomeninges. But they can have a very bizarre morphologies also, and they can look like an high-grade lesions as well in some of the cases. And some of them have been actually classified as a high-grade in the recent new classification of WHO. For example, this particular case, you can see the adjacent meningeal enhancement and thickening with a cyst with a mural nodule kind of appearance. Coming to cavernoma, they have a characteristic popcorn ball appearance with an hemosiderin ring blooming on gradient images, can have associated DVA, calcification can be present, and CT is often negative in small cavernomas. Otherwise, CT can show all those features which I enumerated. And for example, here this is a classical cavernoma picture. You can see there's a lot of blooming and susceptibility, and adjacent actually the blood has leaked and oozed into the adjacent brain parenchyma. You can also have a T1 hyperintense rim around the primary lesion, which is considered slightly characteristic. Coming to tuberous sclerosis, so in this particular condition, lot of cortical hamartomas cortical malformations will be there, or hamartomas will be there. There can be subependymal tubers. There can be SEGA and white matter signal abnormalities. So these are the major features and the minor features, and these are the criteria: definite TSC, probable and possible TSC. So these features are enumerated here, which are many of them are beyond the brain findings. They are related to the skin, renal, as well as other visceral abnormalities. The prognosis of epilepsy usually is poor with increasing severity and frequency, and often they respond very poorly to the anti-epileptic drugs. And subependymal nodules are small, usually less than 12 millimeter, and they are round or elongated protrusion to the lateral ventricles. And SEGA are present in the region of foramen of Monro. If there's a this lesion are larger in size and are showing enhancement, we must think about a tumor or a SEGA. And pathological hallmark of these lesions is the presence of calcification. Ependymal nodules is a calcification, and they start getting calcified after first year of life. So this is another example. You can see these signal abnormalities in the underlying white matter. These subcortical white matter signal changes are there, and you can see the nodules also. In another case, susceptibility, we can show calcification within these nodules. These signal changes are there, which are similar to the cortical malformations. Coming to Sturge-Weber, it's an encephalotrigeminal angiomatosis characterized by facial capillary vascular malformation, leptomeningeal angiomatosis, and choroidal angioma. Seizures are the initial neurological manifestation present in the first year of life. And eventually, most of these patients will develop seizures. There's a long list of entities which can be present, but one of the most important things, the brain changes are most often seen in occipital, followed by parietal, and less commonly in the temporal and the brainstem or cerebellar region. Tram tract calcification is characteristic, and there can be ipsilateral choroid plexus enlargement. For example, this particular case, so it is a focal area showing calcification, focal atrophy, as well as you can see susceptibility here coming here because of the calcification, enlarged choroid plexus, and this enhancing. So this enhancement, this leptomeningeal enhancement may not always be present. So don't think it's mandatory to diagnose it. And there can be overlying bone changes. For example, it can get thickened. So there's a focal atrophy here. Again, there's some amount of calcification here, and not much enhancement actually. So coming to another entity which is important is the cortical and glial scars, which can due to perinatal ischemia, resulting sometimes they can give rise to a particular pattern called Ulega area. We must be aware about it. Already it was spoken about in the morning in the perinatal hypoxic insult talk. And these are characteristic the parieto-occipital region as well as the perirolendy cortex, which shows these changes. So these are pretty straightforward to diagnose, but sometimes the gliosis will be very, very subtle. For example, in this particular case, look at this particular area. Only this is the gliosis. You can see the cortical thinning. So always identify the abnormality on FLAIR images. Go to the T1 weighted images, volumetric T1 weighted images to confirm your finding there and make a diagnosis. Rasmussen's encephalitis is a chronic inflammatory disease of unknown origin. Usually one side hemisphere can be affected, but both hemispheres can also be affected. Most cases occur in children less than 10 years, and it is associated with epilepsy partialis continua. So radiologically, you can have a unilateral atrophy signal. There can be gliosis, it can be very extensive, and by some time relative in rare conditions, bilateral hemispheres can also get involved. So it's difficult to scan the children because they are obviously not going to cooperate as the adults, and so general anesthesia may be required. And because of the ongoing myelination process, it may make the MR interpretation difficult. So it's better to repeat the studies after some time. If the myelination, if the child who is undergoing an MRI is in the where the ongoing myelination process is there. Then another entity which I would like to bring to your notice is that intraoperative ultrasound is a very good, useful technique actually. We do it in our place very regularly. Our surgeons use it because it demonstrates the cortical malformation, and this changes very nicely. So it's an excellent technique for. So the scans are done in a neuronavigation technique, and you can actually, especially for identifying small focal lesions or small calcified granulomas. So this technique is very, very useful because you can put the probe directly on the brain surface and actually will be able to characterize the lesion very well and localize the lesion very well, which are otherwise very difficult to do. So many advanced quantitative methods are coming, which includes use of newer sequences. Some of the newer sequences like MR fingerprinting I have already shown, and its value in making diagnosis in patients of epilepsy. There are some newer contrast mechanisms, for example, using newer estimations from the diffusion data, which can help us to diagnose these hidden entities, especially the MR negative epilepsy scans, and then methods related to machine learning and automated detection, which are all in their infancy. And I couldn't find much literature on type 1 FCD, which are the most challenging, and MR negative cases. So this work is still going on, but none of these have been applied in the real clinical environment. Thank you, and I acknowledge the help I received from my epilepsy team, includes Dr. Sanjeev Sinha and Dr. Bhaskar from the neurosurgery. Thank you.